questions after each of them, so I look forward to the discussion. These are my disclosures. They're going to be the same for both, and I'm going to be discussing off-label treatments for all of these conditions because there are no on-label treatments yet. So the plan for this talk is that I'm going to spend a few minutes defining what we mean by encephalitis, and specifically by this evolving concept of autoimmune encephalitis. I'm going to discuss the differential of encephalitis. I'm going to discuss some representative syndromes and a practical diagnostic approach. And then I'm also going to zoom in on the specifics of treatment and discuss specific protocols and safety monitoring approaches. So let's start in the beginning. An encephalopathy is a term that really everyone knows and deals with every day, but I think it's worth making sure that we're all on the same page in terms of what we mean by these terms. So when we say encephalopathy, we mean an impairment of brain structure or function, altered mental status, and it has many potential causes. When the cause of the encephalopathy is an itis, when it's inflammation, we call that encephalitis. Alternatively, you can have brain inflammation that may be focal. It may not actually cause global brain dysfunction, but pathologically, we would call that an encephalitis. So at its core, what we mean by encephalitis is brain inflammation that may or may not cause an encephalopathy, but usually causes some brain dysfunction from wherever the inflammation is. And this is in contrast to meningitis, which is meningeal inflammation, and then you can start having different patterns, of course, meningoencephalitis, encephalomyelitis. Now, we often lump these terms together in giving talks like this or in clinical practice, but epidemiologically, certain syndromes tend to present with one or the other. But I'm going to come back to these terms, and I just want to be very specific in terms of what we mean here. So the challenge with encephalitis as a field is that for many years, it has been defined by the infectious disease world. Why is that? Because for a long time, it was presumed that the most common causes of encephalitis were infection. And so until this past year, all the major guidelines that defined encephalitis and also defined research case definitions were written as if an infection was causing the problem. So these are just examples of ones from 2008 and 2013 where it was defined as fever, seizures, focal neurologic problems, and then other evidence of inflammation. This past year, there's a new position paper out that I am a co-author on, and this was really spearheaded by Drs. Grouse and Dalmau to bring this back into the 2016 version of encephalitis to recognize that autoimmune encephalitis is an important cause of encephalitis and may have a different presentation than an acute infectious encephalitis. And the proposed criteria are that there's a subacute onset. So what do we mean by that? We mean less than 3 months. In other words, it's a rapidly progressive encephalopathy or a rapidly progressive dementia of working memory deficits, altered mental status, and psychiatric symptoms. So it's not something that's been going on typically years and years and years. Right? This is a new process on the order of weeks usually, and you have to just sort of come up with the limit when you're doing these definitions, but it's really something that is new over the last few weeks, and then has evidence of focality, seizures, and then inflammation, either by MRI or CSF, and then the important reasonable exclusion of other causes. So we're going to talk about all of these in detail. If we step back, encephalitis is a big deal, and it's not as rare as we may think, and it's in particular very morbid and very costly. So the best paper on this to date comes from the CDC, published in Neurology, and they estimated total hospital costs of encephalitis in a single calendar year, 2010. And it was estimated that in the US, there were $2 billion of direct costs attributable to encephalitis. This doesn't include rehab, lost work, all the consequences of encephalitis. This is hospital care. Another way of looking at this is that every year there are about 20,000 hospitalizations in the US for encephalitis. And if you break that down into an incidence rate, it's around 5 to 7 per 100,000. And I give some numbers from other countries in Europe and in Australian numbers, and I think it's sort of remarkable, actually, how similar they are in terms of overall incidence. And in terms of the morbidity and mortality of these in the US, 5% of people with encephalitis die. The rate is 10% if the patient has HIV or AIDS, and the rate goes even up to 17% if it's transplant associated. The leading causes of death are edema, status, and bleeding, so really acute complications of the acute encephalitis. So when we talk about approaching a patient with encephalitis, I think that this diagram gives the practical way most of us approach a patient. And this is different from how a lot of the literature approaches it, where you get reviews on these are the causes of infectious encephalitis, or these are the causes of autoimmune or paraneoplastic. Because when you see the patient in the beginning, you don't know. All you know is that they have a rapidly progressive encephalopathy or some clinical syndrome that's suspicious for an encephalitis. And you need to decide quickly whether there's an infectious cause, whether it's a non-infectious primary inflammatory cause, of which I mean autoimmune or paraneoplastic. And by paraneoplastic, I mean an immune response that was initially driven against a cancer that's now turning against the self, which is a form of autoimmunity. But I break those off because, in practice, you'll see there's actually a different epidemiology for most of these. And then importantly, other causes of encephalopathy, toxic metabolic, neurodegenerative, mitochondrial. The list is very, very long of all the things that can cause a rapidly progressive dementia. And I think that rubric is important as you go down this road to treat delirium if present, and then if there is an underlying dementia, once the delirium clears, to do that entire workup. But when you're working through the concept of encephalitis in practice, the major question is it infectious or non-infectious or other? So the typical approach when someone comes in with an acute meningoencephalitis is that you make the diagnosis off clinical history, off MRI, and off CSF, and then typically you cover empirically while you're sorting it all out. And typically, if you're worried about infection, you would send a broad infectious workup. This is more the acute presentation, someone who's been having slowly progressive changes for weeks and shows up more as a subacute type presentation may not warrant, of course, all this acute infectious coverage. But I'm just saying from a general sense, typically we say when someone comes in with an acute encephalitis, we're on high alert for infection, so you would typically cover for acute meningoencephalitis while you're sorting it out, and I list some of the considerations there. And then once you dig deeper, you're going to consider autoimmune and paraneoplastic causes. Usually you get the tests sent off, and I'm going to talk about all these tests, the serum and CSF antibodies, and then sometimes you wait for results, sometimes you treat empirically, and I'll talk about those considerations. But if you think that this is not infectious and it's autoimmune, then you start empiric immunosuppression for this after you do your best to rule out potential infectious or malignant causes. And when I talk about evaluate carefully for others, what I mean is you really have to work through that infectious diagnosis and also make sure that you're not dealing with anything that your immune suppression could either cloud the diagnosis or hurt the patient. So when we look at the epi, what does this actually look like in practice? When we did an AAN course on this a couple years ago, we titled it somewhat provocatively, Infectious Paraneoplastic Autoimmune. But when you actually look at the data, we should really be saying unknown or idiopathic, which doesn't fill course seats, but it's actually accounting for 40 to 60% of encephalitis cases. So in real life, 40 to 60% of encephalitis cases in the 21st century in the US and in Europe remain in the idiopathic category. So I give you some numbers here and some data. I think the key things are that in general, infectious encephalitis accounts for on the order of a third to a half of encephalitis. And autoimmune counts for about a quarter to a third, and then the unknowns have been coming down over time. If you look at the bottom, which goes back to 2006 in terms of the year looking back, 2/3 of encephalitis cases were unsolved. And now that number is more on the order of around 30%. What's happening here, it's a combination of better infectious disease diagnostics and, importantly, this revolution in identification of autoimmune encephalitis. So our hope is that this number is going to come down. But in clinical practice, we all care for patients where even with sending all the known tests, sometimes the best answer is an idiopathic encephalitis where we may suspect it's autoimmune, but we just don't know yet. And we hope to be able to reduce that number lower and lower over time. So why is it so challenging to pinpoint the specific cause? This is 2016. If we take resources out of it for a minute, we have some of the state-of-the-art laboratory studies to go after infection and to go after autoimmune antibody discovery. Why can't we put our finger on this? And I think there's a couple of reasons. Number one is that the infectious diagnoses can be hard because infectious diagnostics need a bit of a revolution. And what I mean by that is that over 100 pathogens have been described to date to cause encephalitis in humans. That's a lot. And for anyone who knows how we test for infectious disease, if you sort of step back and think of what you do when you order an infectious disease workup, what you do is you essentially create a spreadsheet, either literally or in your head, and start working through all the things that could cause an infectious encephalitis, and then you use your reasoning and Bayesian logic to say what's likely, what isn't, what is testable, how much sample do I have, and where do I start? And so typically what you're able to do, or you can send cultures, but as we know, certain bugs just never grow on routine or even specialized cultures. Just certain things are really impervious to culture. You can send antibodies, but you have to name each one. So you have to say, I want this particular antibody to this particular virus, or I want this particular fungus. And if you don't think of it or you don't send it, you're going to miss it. You can't be sending 100 antibodies on every patient. We just don't have enough CSF. We don't have enough lab costs for that, and it's just not practical. And then the other thing is that many idiopathic cases of encephalitis now, it seems, are probably autoimmune. Some of them are because we haven't discovered the antibody and are rapidly describing new antibodies. Some of these may actually not even be antibodies. It may be more of a T-cell driven response. And I think there's going to be a lot more discovery on that end. So I just want to talk briefly about how the infectious disease diagnostics are evolving, because I think this informs how quickly and how confidently we'll be able to treat autoimmune encephalitis going forward. So this gives the typical 2016 version of how we can work up an infectious encephalitis. At the top, of course, is clinical judgment and exam and history. Then, of course, we have PCRs, we have serologies, you have cultures, and then even brain biopsy. But we published that even when you do a brain biopsy for encephalitis, often the diagnosis remains frustratingly elusive. It might confirm that there is an encephalitis and tell you that it's not malignant, but it doesn't distinguish between infection or non-infection. So one way forward, and this is really a revolution in neurodiagnostics for encephalitis, is unbiased next-generation sequencing. And it may have been coincidence, but it's actually a perfect segue from the last talk when you think about it. Because what we're doing is we're taking the exact same technologies that you heard about for whole exome sequencing in humans, and we're applying those same machines, but we're actually trying to get rid of everything human to look at anything non-human that's left. So let me explain that. What you do is you can take any sample, in this case, spinal fluid. You isolate RNA or DNA. You fragment, amplify, you run it through a sequencer. So these are the same kinds of machines that you do when you send a whole exome sequence to try to figure out if there's an underlying genetic disease. Here what you're doing is amplifying just everything that's in that sample, so everything in the spinal fluid. On the left is all the wet lab, On the right is all the bioinformatics, and you need both to make this work. And I think you saw that in the last talk in terms of understanding and interpreting exome sequencing. It's the same thing for infectious diagnostics. You then take the sequence and use bioinformatics to get rid of everything that's human. So this is the inverse of the last talk. And then what you're left with is everything non-human in that sample. And then you match it to known sequences, and you then identify a pathogen based on the genetics. So this will work for anything that is based on DNA or RNA. It won't pick up a prion, but it'll pick up bacteria, fungus, viruses, parasites, amoebas, et cetera. Anything that's based on DNA or RNA, you should be able to pick up. And you don't have to have asked the question, do you have this infection? You just sort of see what's there. And then the real challenge is to try to figure out if it's noise, if it's background contaminant, or if it's the cause. And that's where we've set up a whole tumor board style panel, much like the geneticists have on the human side, to interpret this in clinical context. My colleague, Dr. Wilson, published this paper in the New England Journal a couple of years ago that you may have seen. It also made the front page of the New York Times with a beautiful picture of the young boy who was saved by this. This was a case of a young boy who had an immunodeficiency. People with immunodeficiencies are actually prone to both infection, of course, but also autoimmunity because of immune dysregulation. So you have to deal with both. They're both plausible. Who had a Meningoencephalitis and had an excellent workup at a top children's hospital in the Midwest, and originally went down the infectious route, couldn't find the answer covered empirically. In the New England Journal, every antibiotic is described, and I think we would all appreciate, all the empirical approaches there. Then circled back to say, could this be autoimmune? Increased immune suppression. The boy went into coma status. FedExed the CSF over to UCSF, and my colleagues in the lab applied this pathway. And within 48 hours was able to identify that it was actually leptospirosis. And for certain antibiotic reasons, they were doing cephalosporins that weren't touching, they switched to penicillin, and the child was able to make a full recovery. And they have this beautiful picture of him playing in his front yard. And I think that this was one of these examples where even to confirm this test, to publish in the New England Journal, took several months because of issues with PCR primers available at CDC, et cetera. In real life, it's very hard to test for certain bugs. And I think that this kind of approach of a unbiased sequencing is likely to change the way we do neuroinfectious diagnostics, and this will directly impact how we think about autoimmune versus not autoimmune. Just one other recent example that we published out of our experience in San Francisco is that this was a 74-year-old woman who came in with a meningoencephalitis. Initially came in with a uveitis, inflammation of the eye, which then rapidly progressed into multiple brain abscesses. And it wasn't for lack of trying. She had 2 brain biopsies. On the brain biopsy, there was a necrotizing vasculitis, covered broadly, really just throwing the kitchen sink, trying to save this woman. Big question is this autoimmune vasculitis versus infection? The clinical sense was this has to be infection, even if we can't prove it through conventional means. Used this technology and found that it's actually an amoeba called Balamuthia that we actually see in California, and would not be part of your typical panel. And what's interesting is, and you can see it on brain pathology, and what's interesting is these cells that look like lymphocytes there on the right. I have a pointer here. These cells here, the big blue cells, in retrospect are actually 2 times the size of lymphocytes. They're actually amoeba. But if you're not primed to that, that can be miscalled as inflammation. And when you go back and stain immunohistochemically, you can actually see that these are free-living amoeba in the brain, essentially eating brain tissue. So this is just another example where we're struggling in real life between autoimmune and infectious, and using unbiased approaches can get guidance that, of course, need clinical correlation. And so we published this last year in Annals of Neurology. And we now have a research protocol, IRB approved, where we accept samples from around the world, in particularly around the country, and can obtain surrogate consent if the patient themselves is unable to have capacity to consent, and do this on a research basis. Our lab at UCSF also just got CLIA certified, so this is now a clinical test, and it's currently in pilot mode under a California Precision Medicine grant at 3 UC campuses to test it for acute meningoencephalitis and validate all the test characteristics that way. But I just flag this because this is now real life CLIA laboratory as well as research protocol at UCSF, and there are others around the country doing this. And I think that this is going to be mainstream very, very soon, if not already. So when we talk about ruling out infection, there's all of those ways that I've talked about. And in our center, we try to push really hard to make sure we're not missing even undiagnosed or undescribed infections. But clinicians have a good sense after just a little while even of making sure that you get the initial test back. There's a lot of MRI characteristics that can help distinguish between infection and not. You have a sense of whether you're dealing with an autoimmune process. And for many of us, you move quickly towards favoring an autoimmune etiology. And so when we break this down, what we're left with is that there's really two main syndromes. There's the autoimmune type cases, and what I mean by these are these neuronal cell surface antibody disorders that I'll describe. And then there's the classical paraneoplastic disorders. These are the ones like the Hue antibody, Rio, that were actually described in the 70s. This is an older technology, and what these are antibodies that target intracellular antigens. So if you think about that for a minute, the antigen is inside a neuron. So in a cell that hasn't opened up, it's not actually clear how an antibody that targets something on the inside would do any harm. And in fact, we don't think that these antibodies on the right there for paraneoplastic that are intracellularly driven are directly pathogenic. We think they're more a non-specific marker of an anti-tumor antibody humoral response, and that when you look on brain pathology, on neuropathology of these patients, it's really a heavily T-cell driven process. And this correlates with our clinical experience that these patients can be frustratingly refractory to treat with humoral-based treatment strategies. And identifying and treating the cancer is really the treatment priority. That was the clinical formulation, and that overlays with the observation that the ones on the left, the autoimmune type cases, which sometimes have a tumor association but often don't, do respond well to immune suppression, whereas the ones that were the classical paraneoplastic intracellular antigen antibody-associated disorders don't tend to respond as well. So what does it mean when you send serum or CSF for paraneoplastic or autoimmune encephalitis antibodies? And more, I would encourage you to be very specific with your labs about what's being sent. Because if you just write paraneoplastic, you might get a 3-test panel back for Hue, Rio, just these intracellular classical paraneoplastic antigens. There's a lot of different panels. A lot of the major labs have renamed these to try to make this easier. To say, do you want all these neuronal cell surface antibodies, or do you just want a paraneoplastic? Are you working up an encephalitis, or are you working up someone with a known cancer who has a neurological problem, et cetera? So I would really encourage you to dig deep. When you hear, that someone had paraneoplastic antibodies sent, that doesn't really mean much anymore. You need to know exactly which ones were and weren't sent. So there's two ways of doing this. On the left are the classical intracellular antibodies, and these were much easier to pick up using standard Western blot and EIA type approaches. Why? Because they're linear antigens. They're in terms of their conformation. They're intracellular, and they don't have complex 3D structures. So usual technologies will work well to pick up those antigens. Whereas if you try to do that with an NMDA receptor, using a Western blot, it won't work as well because it needs to be in its native 3D conformation for the antibody to bind. And so the revolution in that was expressing the antigen on a cell surface and then applying immunohistochemistry, or growing neurons in culture and using immunohistochemistry, or slicing a brain and staining that. So when you send a HUE antibody as an example, you're using classical lab molecular biology for that. For neuronal cell surface antibodies, such as the NMDA antibody, what labs now are doing is expressing it in a HEC293 or a similar cell. So you're essentially transfecting the cell to express it. It's expressed in its native conformation as if it would be in our brains, and then using immunohistochemistry to find that. And then usually the labs will then confirm it with one of these other two assays, either with cultured hippocampal neurons. That's currently research only. That's not part of any CLIA certified lab. Or through brain slices, typically rat or mouse, and then staining it that way. And you have much more confidence when you see it through multiple testing than just through one. And so when we talk about cell-based assays, that's what we mean, and then confirming against brain slices. The beauty of a brain slice assay is that you can see abnormal staining against neuropil, abnormal staining against neurons, the synapses, even if you don't know what the antigen is. So the cell-based assay only works if you know what to transfect, if you know what to express. But the brain slice assay can tell you that there's something binding brain, we just don't know what it is yet. The challenge is that no clinical lab can report that out to you under any CLIA. CLIA is the sort of official lab regulations that say what you can put in a written report and make clinical decisions off of. No one can report that in writing, but many of the major labs, and especially the research labs, will call physicians or at least try to share that information somehow to say there's something active going on here. And when you read the autoimmune encephalitis literature, there are a number of cases where you have abnormal staining. You know there's something going on. We just haven't figured out what the antigen is yet. And when we go back to our vision of how you would do an unbiased approach, we would love to be able to do the infectious diagnostics, both targeted and unbiased, and then stain for both known antigens and then also screen for unknown. And that's essentially what you get at labs that do brain slice assays. But it would be wonderful in the future if that would be able to be reported, to say there's something going on even if it's not named. But you need to communicate with your lab to be able to get that. So this is the emerging paradigm of what's going on. On the left are the neuronal intracellular, what I like to call classical paraneoplastic disorders. They're usually associated with cancer. It's really a cytotoxic T-cell response. We think the antibodies are not the bad actors here. They're really more of an epiphenomenon, and they have a really poor response to immune suppression. In terms of treatment strategies, there are some patients that do respond, and so we will often push hard when someone's not doing well just to give them the best shot. But we need a breakthrough in terms of how to treat these patients. Some of the best observational data comes from the Sloan Kettering experience with using more T-cell directed therapies, such as sirolimus, which may have a very modest effect, but are also quite toxic. So this is a challenging group. In the middle are the ones that I think people are becoming increasingly familiar with, which are the neuronal cell surface synaptic autoimmune encephalitides, and I list some of the classic ones there, that are usually not cancer associated in many subgroups. They're antibody and complement mediated, and there's usually a robust response to immune suppression. And then more and more, I think we can actually reframe other discoveries into this same paradigm. For example, neuromyelitis optica is a neuroimmunologic disorder that binds an astrocytic water channel. So I think we're going to be discovering that this concept expands beyond just nerves. Other examples are the story with MOG, which is a myelin protein, in terms of ADEM, acute disseminated encephalomyelitis, and some children with a neuromyelitis optica, sort of demyelinating disease type picture. So we might be discovering more myelin antigens. And then even the example of amyloid angiopathy with inflammation, what's called CAAI in the literature, is associated with antibodies against A beta. So I think we're also seeing other antibodies targeting protein depositions in brain or outside of neurons, and that's what we're going to be seeing more and more of. So I think this paradigm's going to be expanding to not just include neurons. So let's zoom in on the common neuronal syndromes. This comes from our review in Annals of Neurology, and it just gives you a sense of how common some of these are. In terms of actual incidence of these disorders, it's very hard to find hard population-based numbers, but we think that it's probably on the order of 1 per 100,000 to 1 per 1,000,000, depending on which syndrome. So it puts it on the order of myasthenia gravis, it puts it on the order of neurosarcoid, it puts it on the order of NMO. They're not that rare. And so I'm going to talk about each of these in detail. So let's start first with NMDA. How many people in this room at this point have cared for someone with NMDA encephalitis? So a very large number. And I think it's important to just recognize how new and how fast-moving this field is going. And I think the message from this talk is that even if you haven't, you likely will, because now we can test for it, and we also have a much better sense of what to look for. And it's not that uncommon. This tends to be a disease of the young. So 95% of cases occur in people less than age 45, and a third occur in pediatric age children. This is the characteristic clinical syndrome. There's a vague prodrome, headache, fever, nausea, vomiting. Sometimes people even have a cold, runny nose type symptoms. And then acute neuropsychiatric symptoms. Sometimes there can even be a frank psychosis, and it's not unheard of for these patients to first get triaged to psychiatry as an acute psychotic break until they seize or until something else becomes obvious that you're dealing with an organic, an underlying neurological cause. Then there's a component of amnesia or speech, so memory loss, and then some language, usually a speech disturbance, and then seizures. Often there's a very prominent movement disorder, and for some of you who have taken care of these patients, these movement disorders can be extreme. We've had very unfortunate patients where we've had to wire the jaw shut sometimes to protect patients, who are intubated, and these are very, serious and unusual type movement disorders. And then a subset of patients will have decreased consciousness, autonomic dysfunction, and some progress to frank coma. And some patients, fortunately not all, but there's an important subset of patients that will be intubated in the ICU, sometimes for months at a time, and still can have an excellent recovery with wonderful ICU care and with aggressive immunosuppression. And it's not uncommon for us to get calls from ICU physicians who tend to work more on an every 12-hour or every 24-hour type time frame to say, is this hopeless? Is this, should we be discussing goals of care? And I think the message is this is a syndrome where it can be severe, sometimes for months, but the natural history is that people do tend to turn the corner. And I think we need to, as neurologists, to provide that education to our ICU colleagues. So what do we see? We see that usually there's a pleocytosis, meaning inflammation, elevated white cells. Usually there are oligoclonal bands. These are antibodies unique to spinal fluid that we think are synthesized in the central nervous system that are not present in the serum. Interestingly, the presence of oligoclonal bands depends on when you tap the patient. So if you tap the patient during that prodrome, statistically they're much less likely to have oligoclonal bands, whereas if you tap them after they've already had the disorder for 4 weeks, they're much more likely. And the emerging model of this is that the antibody may start in the periphery, but then enters the CSF, and then there's intrathecal, meaning in the nervous system, generation of an immune response. And then you start secreting NMDA antibodies in the nervous system. This is a very intrathecally driven inflammatory process, which is distinct from some of the other autoimmune encephalitis. And I think important as we think about our treatments, which almost all currently target the periphery, meaning outside the nervous system, in terms of the immune response. MRI is usually normal or non-specific. So this is going to be an example where the MRI can be normal. And the EEG may show epileptiform changes. Sometimes in very extreme ICU type cases, you'll see this finding of a delta brush, but it's not usually something where that's the diagnostic clue. Usually it's pretty obvious by that point of what you're dealing with. The key here is that you can make this diagnosis now with serology. Typically it's CSF, but can be serum. It's an IgG against the GLU-N1, the NR1 subunit of NMDA. 10% of patients who have this disease will have positive CSF antibodies when their serum is negative. So this is one of the few proven examples so far where CSF is superior to serum. So if your serum is negative and you have a suspicion for this disease, you must send CSF. And if you can only get a chance to send this once, send CSF. This is different, for example, than NMO, aquaporin 4, where serum is actually much more sensitive than CSF. Why? Because it seems to be produced in the periphery and then cross. Same for things like LGI1 antibodies, VGKC antibodies. That's much better in serum. But this is an example where CSF is better. This disorder is associated with an ovarian teratoma, a very distinct paraneoplastic association. The interesting thing about these teratomas is they have a component of neuronal tissue and express NMDAR in the tumor. So that's one explanation for how these syndromes happen. And the rate is about 50% in women in that age group, 12 to 45. And you diagnose that via vaginal ultrasound or an MRI of the pelvis. But what this means is that even in young women who have NMDAencephalitis, half of them won't have a teratoma and will be, honest to goodness, autoimmune. Immunosuppression is favorable. There's data from Lancet Neurology that shows a better odds of outcomes, better outcomes with aggressive treatment. And what is typically meant by aggressive treatment, and I'll get to treatment a little bit later in the talk, is high-dose steroids followed by either IVIG or plasma exchange, and then either B-cell depletion, currently with rituximab, and or the combination of cyclophosphamide, so a cytotoxic agent. I think this is going to evolve as we have a better data about other immune suppressants that can target intrathecal inflammation, but this is currently the state of the art. So the idea is that patients who were treated more aggressively do better in observational analyses. We don't yet have any randomized trials in this disorder, although there's a lot of hope to have that. A couple of observations. In California, we have a project called the California Encephalitis Project. This was run through the Department of Health in the state. And they went back, and once this antibody was discovered, and tested their idiopathic cases. And it was actually more common than herpes encephalitis in children in the California Encephalitis Project. So if you step back for a minute, this is more common than something that I think everyone's aware of. And so, I mean, that alone should really put to rest any argument about whether or not the test is indicated. Really, anyone with this, an encephalitis that could fit this picture needs to have this test sent now. The other important observation have been a series of papers recently of children who've had bona fide herpes simplex encephalitis. So this is PCR proven. They've had true viral infection of the brain and then get better and then relapse. And this was well described in a subset of patients with herpes. And they were PCR negative when they relapse. And it turns out that some of those relapsing children actually have NMDAencephalitis as the relapse. So it's a direct proof of this idea of a post-infectious autoimmune process. That's a very small subset of patients, but I think it's just the tip of the iceberg of all the other post-infectious associations we might be able to make in that 50% that doesn't have teratoma. A couple of other interesting papers, just to sort of show you, now that you have a test, you can expand the phenotype. I think this parallels with the last talk as well. Once you have a gene, you can then describe sort of partial phenotypes or form frusts. A group in the Netherlands went back and looked at all cases of postpartum psychosis in sequential fashion and found that 2% of postpartum psychosis patients had NMDA antibodies, and another 2% exhibited staining to some unknown antigen. So up to 4% of postpartum psychosis patients in a dedicated such unit in the Netherlands may have an autoimmune encephalitis. So I think what we're going to start seeing are more and more examples of cases that were never identified. These were patients that actually just weren't treated because no one had picked it up at the time and got better on their own. So we'll have to see if they behave similarly or not, but I think it's a very important and interesting observation. And then, just because this made the newspapers as well, is that there was a polar bear in Germany that had a mysterious encephalitis, and no one could explain it. And they actually even sent the CSF to my collaborators at UCSF using the next generation sequencing, and we were going to solve it, and they were very frustrated when they couldn't find an infection. It turns out that the polar bear had NMDA encephalitis, and it's the first example of a non-human autoimmune encephalitis in the natural world. And interestingly, it happened in a bear in captivity. So, I think there's a lot of interesting biology here. So that's NMDA encephalitis. Let me talk briefly about VGKC encephalitis, which we're hoping is going to get renamed in our neurological consciousness in the future as the more specific antigens, whether it's either LGI1 encephalitis or Caspr2 encephalitis. So what's going on here? VGKC, voltage-gated potassium channel, this is a ion channel that's expressed on neurons in synapses, and it's been known for a long time that there were these clinical syndromes of what were seemingly autoimmune or paraneoplastic encephalitises, but it wasn't until the early 2000s that the antibody was first discovered. And what it was a radioimmune assay, so this special type of test that pulls down the entire ion channel complex. The classic story here with this is that it's unlike the NMDA story, where 95% of cases occur in people age 45 or younger. Here, this tends to be a disorder of people in their 40s, 50s, 60s, sometimes even 70s. So this one could really show up in a dementia clinic or a behavioral neurology clinic, even in the outpatient setting. Usually it's the subacute onset of amnesia, so over weeks, seizures, and then hyponatremia. And I can't tell you how many times I've seen, it called, SIADH, and it's, until it's linked back to the hyponatremia of this disorder. And then there can be dysautonomic features. 90% of cases are autoimmune. You only find an associated cancer in 10%, and even then you're not even sure if it's really a true paraneoplastic or if you just picked up an incidental cancer by looking. This is also one where your MRI can be normal, and even your CSF can be normal. So a third of cases can have a normal brain and MRI and CSF. So if you step back for a minute, the old teaching with paraneoplastic disorders was that if you didn't have an inflammatory CSF and your MRI was normal, you're done. It can't be a classic paraneoplastic syndrome. And that's probably true for the Hughes and the other cancer-associated ones, but it's not at all true for this neuronal cell surface disorder. So a third of cases are going to have a normal CSF and a normal MRI. So you have to have clinical suspicion to send the blood test here. And you make this diagnosis by blood test. And what you see here on MRI in some cases are these classic temporal lobe changes of suggesting a limbic encephalopathy, and you presume encephalitis. So what's actually happening here? This potassium channel complex is more than just a potassium channel. There's a bunch of shuttle proteins, and it turns out that the actual antibodies in these syndromes that are causative don't target the channel, they actually target the shuttle proteins. And it's interesting because in people who have classic limbic encephalitis, they overwhelmingly have LGI1 antibodies, whereas people that have neuromyotonia with encephalitis will have Casper antibodies. And so there were all these phenotypes that weren't explained, and then once the more specific, there was a heterogeneity of VGKC neurologic presentations, and once more specific antibodies were discovered, we're able to now separate them out as LGI1 disease or Casper2 disease. So when you get a patient with a VGKC antibody, it is helpful to ask for confirmatory testing with LGI1 or Casper. And there's some recent papers from Europe saying that when you have a patient with a positive VGKC antibody and negative LGI1, negative Casper, sometimes those patients don't have anything pathologic going on with them. That can be a sort of non-specific inflammatory finding. Some of those patients may have some other protein that hasn't yet been figured out, and so if they have what clinically in autoimmune encephalitis, I would treat them as such. But if you have someone who has positive VGKC, but the clinical picture doesn't fit, if their LGI1 and their Casper2 is negative, there's now an evidence base to say that may be a non-specific marker. And that's why we think we should be more specific when talking about these syndromes. There are a couple prodromes. One is called FBDS, facial brachial dystonic seizures, and it's a very classic seizure phenotype with this dystonic twitching of the face, arm, and leg. It can happen dozens, 30, 50, 100 times a day. The group in Oxford published that when you have FBDS, which is a very unique seizure phenotype, if you hit those patients hard with steroids, you might be able to prevent the encephalitis from progressing even to amnesia. Essentially, if you can identify it ahead of time and treat with immune suppression, you might be able to stop it in its tracks. We also identified that 3 of our patients actually had acute bradycardic syndromes as their initial presentation, enough that at 3 different centers in the Bay Area, cardiology felt the need to put in emergent pacemakers. And then within 2 months, they developed a rapidly progressive encephalopathy with classic limbic encephalitis. And what we think was going on there was it was actually autonomic irritation from the encephalitis, ictal bradycardia, as the prodromal feature. And we speculate that if we were able to identify that, then we might be able to slow things down or prevent progression. All of these patients were diagnosed with sick sinus syndrome. So just briefly, there's a number of other antibodies. I'm not going to go over every one, but just to say that sometimes the phenotypes overlap. So one that's well known now is AMPA antibodies. These are expressed on the cell surface as well. You get a prominent amnesia, same age group as LGI1. These tend to be cancer associated, but clinically you might not be able to tell the difference between AMPA and LGI1. And this is why panels can be so helpful. There's also other examples just to sort of show you the range of things that we see. This encephalitis has a GI prodrome with intense diarrhea. And you got to remember, right, that the gut has as many nerves as the spinal cord and expresses a lot of the same receptors. So this antibody was targeting gut neurons as well as brain neurons and had a distinct phenotype. And every month now, there are new syndromes being described. And there's GABA antibodies and et cetera. And so I think, the secret here is that you got to send panels because the phenotypes currently still overlap. Let me just say one word about Hashimoto's. This comes up. 13% of healthy people have thyroid antibodies. 13%. You might extend that to say roughly 1 in 10 of patients with memory complaints may have thyroid antibodies. That's a lot. So thyroid antibodies do not equal Hashimoto's encephalopathy. This is a very rare diagnosis. It's a very controversial diagnosis. In the Lancet position paper, we acknowledge it and validate it, but I think it's important to be very strict in the definition. So this is an encephalopathy with seizures, myoclonus, hallucinations or stroke-like episodes. You get thyroid antibodies. There's no single cutoff. Our clinical gestalt is they need to be high, very high, in the few true cases that we've seen, but there's nothing in the literature that gives you a cutoff. Brain MRI, by definition, doesn't show anything wrong, and by definition, there's an absence of other antibodies. In our experience, we undiagnose this more than we diagnose this, and often find other underlying neurodegenerative causes. I've seen patients with chronic migraine get treated with immune suppression because they have chronic migraine and thyroid antibodies. I think we need to be very careful as neurologists to be strict in this. And also, even steroid responsiveness can't be used as a diagnostic criteria because people mean a lot of different things, right? It's sort of normal to get more energy on steroids, at least temporarily. So this is a very challenging diagnosis. We don't think that the brain actually expresses these thyroid receptors on the cell surface, so it's not clear that these antibodies are doing anything pathologic either. It's probably a marker of something autoimmune that we just haven't put our finger on. So let me just speak very briefly about immunosuppressive treatment. Let me just say up front that there are no randomized controlled trials. This is expert opinion. It varies by center, but in general, this I think represents a mainstream consensus about approaches. The idea here is that you want to improve symptoms acutely, you want to induce remission of the pathological process, and then maintain remission and minimize risk from the treatment. And then, of course, treat the symptoms. So if you think about this like an oncologist or a rheumatologist, what we're really trying to do is treat people quickly, that's acute therapy, to rapidly suppress harmful inflammation. I think it's important to recognize that a lot of drugs that are aggressive, cyclophosphamide, rituximab, are not acute. They don't work right away. So acute therapy means works quickly. It's what you do in the moment to stop the badness. So an example of this would be glucocorticoids or IVIG or plasma exchange. Induction refers to aggressive or rapid suppression of harmful inflammation. Many induction therapies, while aggressive, are not acute. And then maintenance therapies, meaning it may not be that aggressive, but it sort of holds down the harmful inflammation to prevent it from coming back or doing harm. So this is our typical approach. For acute therapy, we do glucocorticoids plus or minus IVIG or plasma exchange. For induction therapy, if the patient's very ill or the case is severe, we'll do cyclophosphamide plus or minus B-cell depletion. In children, our practice has been to favor B-cell depletion and try to avoid cyclophosphamide. Although there's literature in NMDA of treating with both in combination, which reflects really the CNS lymphoma type treatment approaches, and I also think reflects the history of this disease originally being described and managed by neuro-oncology. And then maintenance therapy can be any number of steroid-sparing agents or even chronic steroids. So just a brief word about steroids. I'll go quickly through this, and I'm happy to spend more time on this during questions. Typically, we hit hard up front. By that, we mean pulse dosing. This is the bioequivalent of 1,000 milligrams of methylprednisolone. You have an option of an oral steroid taper. Note that T cells drop within hours and seroimmunoglobulin within days. And your nadir is 2 to 4 weeks, depending on the dose. So this works quickly. There's data now in multiple sclerosis that bioequivalent doses of IV and oral are the same in terms of MRI and clinical outcomes, at least for MS. And there's also pharmacodynamic data that the area under the curve over a 24-hour period is similar between oral and IV. You get peak dosing with IV, but over a 24-hour period, the same amount of steroids gets in there. And there are these non-inferiority head-to-head trials now in MS. And so for some patients where you might not be, if you're in the outpatient setting, for example, or you don't have you don't have IV access, oral can be a legitimate option, especially if you have to fight with insurance to get authorization. You can just start your steroids with oral until you get your IV. I list all the mitigation strategies. I think the key thing are with pulse steroids to beware of avascular necrosis and neuropsychiatric changes and hyperglycemia. For chronic steroids, there's a lot of management that we need to take ownership of as neurologists when prescribing these, including bone protection, hyperlipidemia, cardiovascular risk. And I would encourage you, if you're the prescriber of steroids, to be specific in your notes for all the risk mitigation strategies used, much like we would do for any chemo-type therapy. Let me just talk briefly about IVIG. No one really knows how it works. The hypotheses thrown out are that you flood the system with a bunch of antibodies. So IVIG is basically a big bag of antibodies pooled from donors, treated, irradiated. We think we've got rid of everything infectious that could hurt you. And it does something favorable to the immune system, either by flooding the system, or it might actually bind antibody to antibody, or it might even have some other influence on these cells, or through other factors that are in there. Typically, we borrow from the neuromuscular literature to treat the brain in terms of dosing. And so this is considered a high dose of IVIG, and we try to be as aggressive as possible. And this is very distinct from what you do to just give back IVIG in immunodeficiency. Big risk here is from the viscosity. You can cause stroke, you can cause clotting, DVT, PE. And so the slower you go, the better. So, when you have an older patient or someone at risk of that, that's not when you collapse it down to 2 days or 3 days. You really want to extend it over 5 days. And then infusion reactions can be risky as well. Plasma exchange means you're removing plasma and giving back something else. And what you're doing is you're getting rid of pathogenic antibodies and other immune substances. And 5 plasma exchanges removes 90% of the initial IgG, assuming no antibody production. So if you have a monophasic process, great, plasma exchange and you're done. But for anything chronic, if you don't chase it with something else, steroids or some other thing, the thing's just going to come back again. So plasma exchange is not a substitute for steroids unless it's monophasic. These are the practicalities. Everyone has it a little different in terms of whether you do it every other day or every day. You have to be very careful with coagulopathies, but this is often considered more invasive than IVIG, but it's very regional. And so there is an evidence base now for using this. We often have to fight with insurance to do this, especially in the outpatient setting. And so I give you some of these, and there's even a randomized trial of plasma exchange in fulminant demyelinating disease that you can refer to. There's no head-to-head data for IVIG versus Plex. Just remember that Plex removes unwanted as well as wanted antibodies, and some of our drugs are antibodies. So it doesn't make a ton of sense to do plasma exchange a week after IVIG. You're just getting rid of all the IVIG. You also have to be careful of plexing out rituximab or even certain molecules like azathioprine or methotrexate. So this is our typical approach for autoimmune encephalitis. Just a brief word about rituximab, and I'll stop here. This is B-cell depletion. B cells express CD20. These antibodies target CD20. But note that the mature B cells that make antibodies don't express CD20. So think about that for a minute. The antibody factories, the plasmablasts and plasma cells, don't express CD20. Rituximab does not get rid of antibody-producing cells. That's why, even in NMO, for example, you may shut down relapses with rituximab, but your NMO antibody is still going to be the same titer for a long time. So it's not an antibody killer. It's a B-cell killer. That said, it seems to work favorably for many neuroinflammatory diseases. And you can use either of the dosing regimens, what's licensed for rheumatoid arthritis, which is the same one we would use for other CNS inflammatory conditions, or the neuro-oncology doses. The key thing is you must pre-medicate with steroids. There's now a black box warning about this in RA because of infusion reactions. So I don't consider that optional in our practice, given the warning now. There is an evidence base, especially in NMDA encephalitis. We've published a very mixed experience with LGI1 encephalitis, mixed because I think we've gotten there very, very late when we've done the rituximab. There's emerging experience for it in other disorders, and we're pretty liberal in using it when usual therapies aren't working. So in terms of where the field's heading, I think we're going to have better treatment strategies. We need to get at intrathecal inflammation, and we're not doing that with any of our strategies. We're going to discover new antibodies. The pipelines and the ability to get these antibodies tested for our patients quicker and with more specificity is just going to get better and better. We're going to clarify some of these putative autoimmune encephalitis syndromes, and I'm very, very excited about the future here with this. And so I'll stop there and take questions. Thank you. Please.
We're very pleased with this lecture. Thank you so much. I need some more lectures to be on the level of San Francisco. But what do you think about the new receptor, the PACAP and VIP receptors? PACAP is a pituitary adenylyl cyclase activating polypeptide, an antibody to these receptors. Do you have some information about this? And VIP?
No, so I'd have to get back to you on that one. I don't have any.
PACAP.
Yeah.
It's a PACAP, the new hormones receptor that regulate the increasing of the CMP.
I think it's something I'd need to look that up a little more, and I'd be happy to get back to you.
Thank you so much.
Thank you. Yes.
Appreciate the lecture. Real quick, should we be worried at all as far as which labs we send these CSF tests to? Meaning, in your experience, have you noticed any variability amongst?
Yeah, so the question is about, should we be concerned about which labs and variability? It's a very important question, and yes is the answer, although we can't always control which labs we send to. I mean, I think we all work in certain healthcare systems, right, where some insurance prefers one lab or another. We can't send out a state sometimes, or it gets complicated. That said, there are, I think for certain tests, like the intracellular tests, any of these labs can do that because that's an older technology. For the cell-based assay, the NMDA test, it's now pretty much a kit. And so as long as it's a reliable lab that you actually trust their processes, as long as they're all using the same kit, that's reliable. But the difference is very few labs will do confirmatory testing with brain slices. And so I would encourage you on cases where it's not obvious what's going on, and if you're not getting access to them, that you push hard to send to those labs to say, is there abnormal staining, even unofficially, to suggest an autoimmune encephalitis, even if we haven't figured out the antibody, or more importantly, if you have a positive serum, but it doesn't make a lot of sense to send the CSF and also say, is it confirmed through brain slices? Major labs are sort of Quest Athena, and then Mayo Clinic has really excellent neuroimmunology laboratory in the U.S. There's also important research laboratories that can do this. At our center, we're not able to send to research unless we have an IRB protocol because it's not CLIA certified, but often you can get access to it. And I still think until this field gets more mature that there's value in research testing when you know there's an encephalitis and you just haven't figured out the antigen. But I think if one of these major labs is negative and you either have to say it's an autoimmune encephalitis because of other things and I'm just going to treat empirically and I just don't know the name, or you need to say that we've screened for all the big things and we can be comfortable with that. So I think it's less about which lab and more about which tests. The other thing I would say is that certain labs don't offer the newest ones. You have to look very carefully. The AMPA, the GABA, they're all going to be offered in the next year or two by all the major labs, but some of them don't offer the newest cell surface antibodies and DPPX antibodies. So some of those you can only get through certain labs. And then through IP issues, certain paraneoplastic labs are only offered through, by Quest and not Mayo, et cetera. So to really cover your bases, you might need to send to more than one lab. In terms of variability, we've actually seen some variability on the research side of things, but fortunately not as much on the clinical side of things. The biggest variability you'll see are cutoffs. So for example, different labs will put a different cutoff for normal or abnormal for VGKC. So in the UK, for example, they might put their cutoff at 100, whereas here in the US, they might call it 400, or, and they all use different units and things like that, but that may explain why low positive may mean something in one lab and be called negative in another. Just one last point I'll say about labs is GAD antibodies. You have to look very, very carefully at the value. A lot of the mainstream labs actually report their abnormal values for GAD antibody based on diabetes, not based on neurological disease. So as an example, 70% or 80% of type 1 diabetics have low-grade GAD antibodies. And in our computer system, when you send to a mainstream national lab, it'll get flagged as abnormal if you have anything that's even just a blip above normal because it's based on type 1 diabetic norms. But we all recognize that neurological association doesn't happen until you're at 30 to 100 or 1,000 times that titer. And even though the computer will come back as saying abnormal. So you have to really look at relative titers. So I think that's going to be something we need to educate the community about as neurologists. Thank you for the question.
How long is maintenance therapy, and do you follow just the clinical response, or do you actually follow antibody titers?
So another great question. So the question is, how long is maintenance therapy, and do we follow titers? Let me take the second question first. The answer is there's no proven association between titer and clinical response that you can use clinically. So let me give you just one caveat there. We know that serum NMDA titers, to talk about NMDA titers specifically, don't correlate that well with clinical response, but CSF titers do. So we think that as you get better, your CSF titers go down. But there are some patients who get completely better from their NMDA encephalitis, and even 15 years later, still have detectable antibody. So there's something else going on there, and the party line, and I agree with this really, is treat the patient, not the antibody. Does that mean I don't sometimes look and do? I do sometimes, because I want sort of as much information coming back if the patient says, you know, I might be relapsing, and there is a relapse risk of probably 10 to 20% with NMDA. In terms of how long to treat, this varies a lot by center and I think has to be individualized. It's also, I think, based on how severe the original syndrome is. We think NMDA is pretty much a long monophasic course where when you relapse, you know, and there's a 10 to 20% relapse, it's usually within the first year or so. You know, it's not something where you relapse 10 years later. So often we will treat for a year to a year and a half to 2 years, although not always. I mean, if someone's doing so well, they don't have a, you know, if they're just doing so well and we can watch, we might just wait, and if they are unfortunate enough to relapse, we'll treat. But most people will treat for a year or two, but not 10 years. For things like LGI1 encephalitis, the natural history too seems to be this acute process that then dwindles over a couple of years, although we've all had patients where we think it's smoldering for a few years. So often those patients are treated for 2 years, 3 years, 5 years, and we sometimes will keep them on maintenance immunosuppression that way. So I think a lot of this varies on the syndrome. And then some of these newer ones, the AMPAs, the GABAs, we don't know. I mean, you know, the case series are 20 patients, 30 patients, and we're still figuring that out. We also struggle with how to distinguish active encephalitis from damage that's already done, especially when your MRI doesn't tell you that. There may be a emerging role for PET, but that still needs to be figured out. And then I think, you know, titers might be helpful. I mean, if they still have antibody and they're not doing well, often we'll treat, even though that may not be the right thing to do.
Sometimes we send several different things on these patients. 14-3-3 protein, can it be seen in these patients?
Sure, so the question is about 14-3-3. So this is one was classically described with Creutzfeldt-Jakob disease, prion disease. It's not specific nor sensitive for CJD, period. That said, it's often elevated. You know, it can be helpful in sort of putting the whole picture together, but it's a non-specific neuronal breakdown marker. I co-direct my autoimmune encephalitis clinic with Michael Gelfand, who's an expert in rapidly progressive dementia and CJD, and we've actually been sending nerve breakdown proteins. We sometimes do neuron-specific enolase from CSF. We also will sometimes look at tau. You know, and the question is basically, if we're not sure if the process is still active, we might look and see, is there evidence of nerve breakdown? I don't know if that's right or wrong, but we see 14-3-3 elevated in autoimmune encephalitis when it's not CJD. And we've also published that VGKC can sometimes even have the flare, so not the flare, the diffusion MRI abnormalities that can almost be a fake out for CJD. So, you know, the reason that he and I started together is that the #1 diagnosis in his CJD referral practice and research program, when it wasn't CJD and wasn't some other neurodegenerative disease, was a reversible autoimmune encephalopathy in a remarkable number of patients. So if you think that people were told they had CJD and the answer was actually a treatable autoimmune encephalopathy, that's a big difference. Yes?
Thank you for the great lecture. I have a question. If a patient can, like we diagnose him with autoimmune encephalitis, do we need to follow on, like do a cancer surveillance every 6 months? And if so, how long we will continue to do that?
Yeah, so it's another great question. And this is, again, opinion and sort of consensus and not well studied. There is a European Neurological Federation, I think it's EFNS, that put out a position paper on screening for paraneoplastic syndromes that I find to be particularly helpful, and you can actually have an evidence base, but that refers to paraneoplastic. So if someone has a Hue antibody, I mean, you're on high alert to say, where's the cancer, even if I can't find it. And so for those patients, the classic screening is to do full body scan, so chest, abdomen, pelvis, CT, with and without contrast, and then PET, FDG PET. Remember, in men, you need a testicular ultrasound to pick up testicular tumors and lymphoma that you might not catch on CT or PET. And in women, you need mammography or breast MRI to pick up tumors that you won't see on CT or on PET. So the screening is pan-CT, usually PET-CT, although sometimes insurance will make us stage it, and then testicular ultrasound in men, breast MRI or mammo in women, and then for NMDA, teratoma screening. For NMDA, we typically screen every 6 months for at least a couple of years to make sure we're not missing even a microscopic teratoma. Interestingly, whether or not you have a teratoma, those patients respond to immune suppression similarly in the large series. So it's not necessarily a rule that just because they got better means that they don't have a teratoma. I mean, it's still worth looking. For these other syndromes, we typically will screen for about 2 years and then say, if we're not seeing anything, I'll have an informed discussion with the patient and say, I think we should stop looking, and then we use epi, right? If it's LGI1 encephalitis, 90% of those patients don't have cancer. So I'm not sure irradiating them does that. If it's AMPA, where 2/3 of those patients have cancer, I'm going to push a lot harder. So I think you need to be informed by the syndrome. Thank you.
Okay, so we have a break until 3:30, and then we'll have another informative talk. So.
How fast did all the years go? I never meant to stay away so long. The simpler times forgotten till I close my eyes and see him alive. You place your